Shall we? 8 o'clock.
Um, yeah, we can start, sir.
Good evening, ladies and gentlemen. Welcome to another exciting episode of Secrets of Neurology. It's a knowledge feast for all neurologists. Today, this is episode number 23rd. We are about to have close another second year. And today we have the case study from the team of prestigious Amrita Institute of Medical Science, Kochi. A very, very warm welcome to our course director, Professor Dr. Sudhir Shah and Dr. Lakshmi Narasimhan sir. And also a warm welcome to the faculty and residents and senior residents of Amrita Institute of Medical Science. Today we have an interesting case on myositis plus syndrome. Warm welcome to Dr. Gino Vincent, Dr. Gopi Krishnan, and Dr. Anant Kumar sir. It's my honor and privilege to briefly introduce Professor Dr. Sudhir Shah sir. He knows, the entire country knows him very, very well. Professor and head of the department at prestigious NHL, MMC, and SVPI MSR Ahmedabad. And sir is also director of neuroscience at prestigious Sterling Hospital, Ahmedabad. Many awards and accolades to sir's credit, but I can't say these three at least because of his work in the field of neurology, help to the community and patients at large. Dr. Shah has been conferred the prestigious Padam Shri. Sir is also recipient of Dr. B.C. Roy Award, an academician par excellence, author of 6 books, and sir's interest is into stroke, neurodegenerative disease, and epilepsy. A warm welcome to our course director, Dr. Lakshmi Narasimhan sir. He'll be joining us soon. May I request Dr. Shah sir to take it forward from here.
Thank you, friends. It's a real privilege to be with all of you once again on this mega, long-lasting, most awaited, coveted webinar series that is Secrets of Neurology, Pulse of Wisdom. This is the 23rd consecutive monthly program, which is held on every month's last Friday from 8 p.m. onwards. And I'm sure people across the India, why only India, people from neighboring countries, from Sri Lanka to Bangladesh to distant countries like Spain, UK, and USA, they are all very keen to join this program on time, and I'm sure they are all here. I have pleasure in extending my warm welcome to all the delegates and thank you for their patronage. I want to thank my co-course director, Dr. Lakshmi Narasimhan, my personal friend, a voracious reader, writer, author, a man with tremendous capabilities, with more than 130 students so far under him, and producing voluminous work in the field of neurology. Without his help, I don't think I could have pulled on so long. So thank you, Dr. Lakshmi, and we wish that he joins soon. Well, may I have the next slide, please? I want to thank INTA's Global Cell Division, led by Mr. Chadda, Dr. Haley, Dr. Manoj, and the team for the wonderful networking and tremendous support for this program. Today we have Amrita Institute of Medical Sciences is going to present the wonderful case, myositis plus syndrome has been said, and the presenter, resident doctor, is Gino Vincent. Next slide, please. The discussion, first discussion could be the Assistant Professor, Department of Neurology from Amrita Institute of Medical Science, Kochi, Dr. Gopi Krishnan U. As we know, he is a DM neurologist from Suchitra Institute, and here is postdoctoral fellowship in neuromuscular disorders at NIMHANS. May I have the next slide, please? And above all, the most wonderful personality of today, Professor Dr. Anand Kumar A. He is the HOD and Professor, Department of Neurology at Amrita Institute of Medical Sciences. Currently is the Vice President of the same institute. What to say about him? He's a teacher par excellence. Everybody knows him across the country, how wonderful teacher he is, how wonderful human being he is. He has multiple publications. He's author of books in cognitive and clinical neurology, a lot of papers he has. And above all, he is a man with a multifacetedness. We have heard his wonderful songs, a musician, wonderful singer. He gives spiritual discourses. It's a real matter of joy to listen to his talks of neurology, spirituality, and so many other of this. He's also writes beautifully on subjects of spirituality and other philosophical aspects. So I think we are very grateful to Dr. Anand and his team for accepting today's invitation. I'm sure we'll have a lot of fun for today with a lot of pulse of wisdom and good learning of the subject. With that, I may invite Dr. Anand Kumar, please, to deliver the discussion from now.
Thank you, Dr. Sudhisha, for this kind words of introduction. Coming from you, I treasure these words for my lifetime, because you are a man of such stature, and I never expected that you knew so much about me.
Everybody knows about me.
Because I am a great fan of yours, especially your teaching, your books, and also your Hemant Kumar songs.
You are a very humble man, sir. Basically, you sing much better than me.
No, never. Maybe one of these meetings you can play your video.
Sure.
So we will be presenting a case of a muscle disease with some complexities. So initially, the case will be presented by Dr. Gino, and he will also do the symptom analysis. But the case discussion on the prioritized hypothesis will be by Dr. Gopi Krishnan. And after that, examination, again, discussion on examination by Gino on the clinical side. And with the examination findings and the investigations, Gopi will again come back and do the discussion. And I hope nothing will be left for me after these two have their performance. So without any wastage of time, let me call Dr. Gino to start the process.
Yes, sir. Thank you, sir. Is my slides visible?
Yeah.
Yes, sir.
Yes. Good evening, respected teachers and my seniors, colleagues here. So first at the outset, I will thank the course directors and my professor HOD sir for giving me this opportunity. So getting on to the case, now I'm presenting a case of a 57-year-old right-handed woman, straight up to 12th standard, presented with complaints of acute onset tingling and weakness of all 4 limbs for the past 5 days. So she had a prequel to the story, which was patient was normal almost 7 months back when she started noticing intermittent tingling paresthesias in tips of fingers in both hands. She couldn't recollect exactly which fingers started or involved. she complained that this abnormal sensation from the fingers extended almost to the whole hand in few weeks, and recollected the pain was more in the palmar side than the dorsum of hand. She gives history of worsening of the sensation with cold, and she used to keep her hands warm to avoid these sensations. Then she sought some medical help and she was diagnosed with CTS. Her pain and paresthesia worsened significantly over the last 2 months, and she was advised surgery, for which she underwent CTS surgery under local anesthesia in the left hand in this month on 11th in another hospital. And now coming to the present story, following the surgery, the same day she noticed tingling sensation in the both lower limb distally. It started symmetrically, and over the course of night, she could feel that it was ascending. In the next day morning, when she tried to ambulate, she felt definite weakness of both the lower limbs. When she tried to stand, she couldn't stand, and she also had buckling of knees. Since that day, she has been bedbound. And following this, gradually over the next 1 day, this weakness and paresthesia ascended. And by 2 to 3 days, she had involvement of upper limb also, both proximally and distally. That is, she couldn't lift her arms over the shoulders, neither she could use the distal hands to mix food or to button her dress. She was not able to roll over in the bed. She had some difficulty in lifting the neck above the pillows also. She had occasional cramp-like sensation in the thighs, but she complained no breathing difficulty or no swallowing complaints, and no breathlessness on lying down. No complaints of difficulty in appreciating pain and temperature, no complaints of difficulty in appreciating touch, no history suggestive of cranial nerve involvement. She did not have any difficulty in closing the eyes, or any angle of mouth deviation or drooling of saliva, or any nasal regurgitation or nasal twang in the voice. No bowel bladder complaints, but she was catheterized on day 2 from the outside hospital because of the mobility issues she was having due to the weakness. No febrile illness preceding the symptoms. She had no history of recent COVID-19 infection or vaccination for the same, and no history of neck pain also. But along with this onset of weakness, she gives history of multiple reddish, painless, non-purpuric skin lesion in shin of both legs, anteriorly and laterally as well. And she also complained that there is history of persistent bluish discoloration in both the middle fingers for the past few days. No history of joint pains, no dryness of eyes and mouth, no genital or oral ulcers, no photosensitivity or weight loss, no chronic diarrhea or toxin exposure. In her past history, she was a hypothyroid patient, and she was on thyroid hormone replacement at 100 micrograms per day. She was not a diabetic, not a hypertensive, and she's on no other long-term medication. Personal history, she consumes mixed diet, and family history, no history of similar illness in the past. Functional history, at presenting to our hospital, she was bedbound, requiring support to do all her daily active living. So with this history of the last 5 days, she presented to us, but we were interested to know what exactly was happening in the first 7 months, that is 7 months before this current illness. So we again revisited her and reprobed her with questions, and this time she gave a slightly different history. The complaints of paresthesias were there. With that, the hands become very pale, and following which, after the hands become pale, she noticed that her both hands becomes very red, which is associated with intense pain, and she always felt this was worse with exposure to cold or in cold season. Hence, she used to always keep her clothes soaked in lukewarm water and wrap around her hand, or when the sensation comes, she'll immediately dip her hand inside lukewarm water. So this was suggestive of a Raynaud's phenomena. So now summarizing, a 57-year-old female with a background picture of probable Raynaud's phenomenon, presented with acute onset symmetrical progressive neurological syndrome with paresthesias, followed by weakness involving all 4 limbs and neck muscles, without any cranial nerve involvement or bowel bladder involvement, with skin rashes and discoloration in the both middle fingers. So now we have a timeline here. So timeline is very simple. So for the past 7 months, she was having paresthesias in bilateral hands. So this month on 11th, she underwent CTS surgery in the left hand under local anesthesia, following which same day she noticed paresthesias and ascending weakness from her by both lower limbs symmetrically, and over 3 to 4 days she has become completely quadriparetic with neck weakness also is present. So before we go into the symptom analysis, we felt the Raynaud's phenomenon was really catching our attention. So we'll just go take a small detour and have a word on the Raynaud's phenomenon. So this Raynaud's phenomenon was first described in 1862 by Maurice Raynaud in a 26-year-old female, and he very specifically says it was triggered by moderate cold. So here there will be three stages. First is a stage of ischemia, where the patient says there is a pallor in the hands. That is due to vasospasm. So moment this vasospasm becomes more, the distal ischemia develops. That distal ischemia will dilate the venules even more. At that time, we will hear the cyanosis, and following the relaxation of the vasospasm, because there is significant dilatation of the capillaries and the distal venules, the blood rushes in and causes the hyperemia or the redness. So this is a highly localized phenomena which affects specific areas like finger, toes, and tip of nose and ears. This is specific because of high density of AV anastomosis, which bypasses capillaries and provide direct connection between arterioles and venules. That's why we specifically see Raynaud's phenomenon in these places. So it can be either primary or secondary. Primary we know will be idiopathic, and secondary is of our interest in this patient with the age more than 50. So rheumatic diseases will be the first priority, which will be scleroderma, SLE, dermatomyositis, Sjogren's syndrome, unclassified connective tissue disorder, mixed connective tissue disorders, and hematological diseases like cryoglobulins, cryofibrinogens, paraneoplastic disorder, cold agglutinin. In endocrine disorders, it can be hypothyroidism, and then vascular disorders. And interestingly, neurological syndrome like CTS can also trigger Raynaud's phenomena, which we'll discuss later. Environmental triggers like vibration exposure and frostbite. Drugs are also very important, and toxin exposure, including sympathomimetic drug, interferon alpha 2b, ergotamine, and some chemotherapeutic agents. So now we will just come to a discussion on symptom analysis. So here we have three specific symptoms. 7 months back, it started as paresthesias of both the hands. But here the important thing will be, it was an intermittent paresthesia, which was associated with pain and also color change. So as we discussed, it is probably suggestive of a Raynaud's phenomena. So when it's a Raynaud's phenomena, and she says the palmar surface of the hands were more involved than the dorsum of the hand, we would like to first keep a localization to a peripheral nerve, maybe a median nerve involvement. And then over the time, from the surgery date of 11/5/2022, she complains of ascending paresthesias and weakness. So here there is a sensory involvement and a motor involvement. So from distal to higher up, we'll start with peripheral nerve. There is multiple peripheral nerves, which is definitely a possibility, which can present with paresthesias and weakness. But the little atypical thing will be, it had progressed proximally also. Proximal involvement can be a little difficult to explain with just peripheral nerves, and also involvement of neck muscles also. So the second will be a plexus. Plexus again, bilaterally symmetrical, we'll keep it down the list. And then third will be a root, which is definitely a possibility. Multiple root involvement can present with this in picture. And then a spinal cord also cannot be ruled out at this point of our discussion. And trunk and neck weakness can also be explained with the same disease process that is affecting the lower limbs. So now, to localize clinically, we have to answer certain questions. So first question in that list will be, where is the lesion? So first, our question to be answered, is it an UMN lesion or is it a LMN lesion? In this case, I consider LMN likely, because there is, as per history, there is no involvement of any cranial nerve, but there is a quadriparesis. So for that to occur, the lesion should be somewhere in the high cervical cord. With the cervix for a UMN lesion. So with the high cervical cord lesion and such profound weakness, we expect a bladder involvement, which is not there in this patient. So that at this point of time will argue more towards a LMN rather than a UMN lesion. But still, an UMN lesion totally cannot be ruled out at this point from the history. So once we are now considering strongly a LMN syndrome, then we have to think about what are the substrates that could be involved. So from the history, the nutshell, we know that it is a symmetric disease, an ascending weakness with sensory involvement also, and there is no bowel bladder involvement. So first, if we go from above downwards in element localization, it can be either of the 6 structures. First, if you take anterior horn cell, the sensory symptoms itself will directly rule out an anterior horn cell involvement. So we will keep it down the list. Then, as we discussed in the previous slide, multiple roots involvement is a radical involvement is a definite possibility in this patient, because there is sensory involvement and also motor involvement. So that will be considered. We have to consider root involvement. Plexus, though it can also present with weakness and sensory involvement, for this picture to get, that is both upper limb and both lower limb, both the brachial plexus and the lumbosacral plexus bilaterally has to be affected. So hence it comes little lower down in the list. Then a multiple peripheral nerves involvement is again a possibility that can explain the symptoms. But as we discussed before, to bring in a proximal weakness, a radical looks a better bet than a peripheral nerve. But at this point, we cannot rule out a multiple nerve involvement also. For a neuromuscular junction involvement, usually there is a proximal weakness and fatigable weakness, and also there will not be sensory complaints. So hence that also will be much lower down on the list. And then for a muscle to be involved, again the sensory symptoms is strongly arguing against a muscle disease. So at this point of time, we will keep the substrate involved to multiple radicals with or without peripheral nerve involvement is what we can provisionally think at this point of time. But again, there can be a majority of the contribution from this structure, and other structure involvement we cannot rule out 100% with now. That is multiple substrate involvement. So then to define this further, we have to give a syndromic pattern. So we have seen where is the lesion, then we have seen what are the substrate involved, and now we have to give a syndromic pattern. So as we discussed in the previous slide, now we are thinking about a polyradiculoneuropathy, multiple radicals and peripheral nerves. So that is a syndromic pattern for this patient. So it was acute, it was progressive, it was symmetrical, and the systemic illness to explain along with this will be Raynaud's phenomena. And there is no strong family history. So the next step of our approach will be etiology and differentials approach, which will be done by Dr. Gopi Krishnan, sir.
Good evening to all. I'm Dr. Gopi Krishnan, and I will be taking you through the various possible etiologies and differential diagnosis we considered in this patient. So at the level of history, as Dr. Gino has summarized, we have a 57-year-old lady who, with a background history of what sounds like Raynaud's phenomena, now has presented with an acute onset of ascending paresthesias followed by quadriparesis, everything developing within a period of a few days. So what really stands out from this history from a usual neurological cases is the presence of other extra neurological manifestations, especially in the form of a Raynaud's phenomena and a recent onset of skin lesions, which the patient has reported since the onset of the weakness. So now Raynaud's phenomena, as we know, is generally seen in association with, it's like a marker of systemic autoimmunity, especially in the setting of vasculitic autoimmunity. So given this context, the first possibility, the group of conditions which we like to consider would be inflammatory vasculitic conditions. And of the lot, systemic vasculitis presenting with a polyradiculoneuropathy seems to be the most likely cause in the current patient. We say systemic because non-systemic vasculitis is unlikely to have cutaneous manifestations and unlikely to have such Raynaud's phenomena. So systemic vasculitis, and because our localization is a polyradiculoneuropathy, this causing a polyradiculoneuropathy seems to be the most likely diagnosis in this case. So moving on to other possibilities which we'd like to consider. Now, if we were to discount the Raynaud's phenomena and the skin manifestations, for example, from the history, quite often we may not be very sure what the patient is describing may or may not be true once we come to the examination. So just to keep our possibilities wide, for the moment, let's discount the possibility the patient is having a Raynaud's phenomenon. So other possibilities which we can consider at this point is a non-vasculitic immune-mediated conditions. And of the lot, the most common thing which we see presenting with an acute onset of paresthesias followed by weakness would be a Guillain-Barré syndrome. And among Guillain-Barré syndrome, the AIDP and the AMSAN variant are the two variants which can present acutely with the quadriparesis and sensory symptoms. Now, a second possibility of an acute presentation of CIDP is also kept here, mostly because the patient gives a history of about 7 months of having paresthesias in the hands, which may or may not be related to the current event, but because such a history is present and this has progressed on to develop an acute onset of quadriparesis, an acute presentation of CIDP also cannot be totally discounted at this point of time. Moving on to the next set of etiologies and differential diagnosis, one set will continue, we will consider our infectious causes. So among infectious causes for acute onset of polyradicular neuropathy, we would consider HIV. HIV, especially in the period of seroconversion, can have a GBS-like presentation. So that is something on our differentials. Next is hepatitis B and hepatitis C virus. Here, these two viruses are more likely to cause such acute onset of symptoms with systemic vasculitis, which is caused indirectly by this viruses. Rather than the virus per se causing a polyradicular neuropathy, it is the systemic immune response to the viruses which can present like this. Cytomegalovirus, Epstein-Barr virus, and varicella zoster viruses are three conditions which can directly cause polyradiculitis. So we will consider them also. And then in our part of the world, scrub typhus, dengue fever, leptospirosis are three common infections, and all three conditions have been described to have a GBS-like presentation, or they can trigger a GBS-like presentation. However, our patient never had a fever anywhere during the course of illness, so these possibilities seem much less likely. So Lyme's disease is a condition which is quite commonly reported from Western literature, not very commonly reported from Indian literature, but there are reports of especially cutaneous lesions of Lyme's disease, as well as seropositivity of Lyme's titers from many areas of India. So we will not totally discount that as of now. Tick paralysis are also a very rare condition, not commonly reported from India, but given the situation and just to keep the discussion open, we'll consider tick paralysis also. Now, moving on to the metabolic and endocrine disorders, which can present with a rather acute onset of quadriparesis. The five we can think of are: one is hypokalemia, porphyria, hypophosphatemia, and hypercalcemia, and hyperthyroidism. Now, hypokalemia, as we generally see, present with a periodic paralysis. But a primary periodic paralysis seems much unlikely in this patient given her age. She's already 57 years of age. So if at all she has a hypokalemia related weakness, it's likely to be a secondary cause. Secondary causes in the form of either drug induced or because of any GI loss, renal loss, or sometimes even renal tubular acidosis can develop later on because of complications of Sjogren syndrome. So in those contexts we can think of, but again, the current persistent weakness lasting for over 4 or 5 days in this patient, as well as the other markers of systemic autoimmunity, make these much less likely. Porphyria is a condition which can present with a GBS-like presentation, but generally porphyria presents at a younger age, and patients usually have a prodrome of severe abdominal pain and some behavioral disturbances prior to the development of such a fulminant quadriparesis. Hypophosphatemia and hypercalcemia usually happens in the context of a hyperparathyroidism, and they too can have a GBS-like presentation. And finally, hyperthyroidism is also differential, but our patient doesn't fit into any of these categories. So just for discussion, we'll keep them, but seem to be quite unlikely in our patient. Moving on to toxic conditions which can present fulminantly. You have heavy metals like arsenic, lead, and thallium, which can have a very acute presentation. Also, organophosphorus poisoning and alcohol-related polyradicular neuropathies can have very acute GBS-like presentations. However, there is no history to suggest any toxin exposure in our patients, so these appear much less lower down in our list. And finally, nutritional neuropathies. So among the nutritional neuropathies, the one condition which can present so acutely is a thiamine deficiency. So again, thiamine deficiency will appear in a list, but usually thiamine deficiency happens in the setting of chronic malnutrition, alcoholism, recurrent vomiting like in a hyperemesis, which doesn't seem to be the situation for our patient. So again, seems unlikely. So like Dr. Gino has already mentioned, at this point of time, just from the history, we cannot totally rule out other potential localizations. So if we consider a cervical cord myelitis as a possible in this patient, an immune mediated or an infectious myelitis can have such an acute presentation. And finally, myositis also appears in this list mostly because of the prominent Raynaud's phenomena that the patient is having. So one of the conditions, neurological conditions, which is strongly associated with Raynaud's phenomena is are idiopathic inflammatory myopathies. Of that, overlap myositis and the anti-synthetase antibody-mediated myositis are commonly associated with Raynaud's phenomena. So given this association, even though the patient has prominent sensory symptoms, we will not totally discount other possibilities also. So myositis also has we have put in this list. But overall, considering the possibilities, what seems to be most likely in our patients seems to be a systemic vasculitis related polyradicular neuropathy, with a slightly distant second possibility being a Guillain-Barré syndrome. So we will proceed with the what we found on examination. Dr. Gino will take over.
So continuing with the examination, general examination, patient was conscious, oriented, he was very cooperative, vitals were stable, and we noticed discoloration in the both hands, in fingertips and middle finger. No Gottran's papules or heliotropic rash was noted, but we observed cola-colored urine in the patient, and then maculopapular non-branching palpable purpuric rashes were noted in both the legs, in the anterior aspect and also lateral aspect. Then mechanic's hand was observed, which is hyperkeratosis in the lateral aspect of the fingers. And on the day of admission, there also mid-face erythema was also seen. So we'll share a few photos. The one on the left top, that is the mechanic's hand. You can see there's a hyperkeratosis, and we can see observably the skin is much thicker on the lateral side. And the top row middle picture, here we can see there is depigmentation of the skin around the forehead, the top area. And this depigmentation is associated with a retained pigment in the perifollicular area. So this is called the salt and pepper appearance. And in the right extreme film, we can see there is graying, like a cyanosed finger. The middle fingertips can be seen. It was seen in both the hands. And the lower picture, the first picture was the cola-colored urine, which actually the patient did not complain at all. She was not aware of also. We noticed on the admission. And then this was the purpuric rash, which was noticed in the lateral aspect of the legs. And continuing with the CNS examination, higher motor functions were normal, cranial examinations were normal, motor system bulk was normal, tone was reduced in all four limbs, no involuntary movements were noted, and muscle tenderness was observed in both thighs and calf muscles in both the lower limbs. And power examination, the neck flexion and extension both were weak, around 3/5, and upper limb, both the sides, all the muscle groups were weak, with distal being more weaker than the proximal. Lower limb also similar pattern, all the muscle groups were affected, and distal was a little more involved than the proximal. All the reflexes were absent. In sensory system examination, pain and temperature setting, it was affected in a glove and stocking pattern, and there was a graded sensory loss were also noted. And touch also similar affection was noticed. Joint position sense were impaired, and vibration sense was absent for the patient. In other systems examination, respiratory system was normal vesicular bed sound, no added sounds were observed. CVS examination was normal, and abdomen examination was normal. So by the end of examination, we have become wiser by addition of two more substrates to our initial hypothesis after history. So now we can hypothesize there's a muscle involvement because of the muscle tenderness, and also a cola-colored urine which was observed. And second, there is extensive cutaneous involvement with a lot of skin markers, and also leukocytoclastic vasculitis, which is manifesting as a purpura. So now the substrates have expanded from multiple polyradicular neuropathy to muscle involvement and also the extra neurological involvement, including the skin and also the Raynaud's phenomenon. So we will try to take this approach a little further before we come to a clinical conclusion. So now we are suspecting a vasculitis kind of picture because of the skin lesions. So vasculitis can be approached on 4 types, 4 subheadings. One method will be a specific vasculitis versus a non-specific vasculitis. Second will be the size of the vessels involved. Third, involvement of either the artery, veins, or both. And fourth, whether it's a central nervous system vasculitis or a peripheral nervous system vasculitis, or whether both is involved. The most common vasculitis approach we use is this one with the size of the vessels, which is large vessels, medium vessel, and small vessel vasculitis. So as you know, the large vessel vasculitis includes the Takayasu and Jain cell arthritis. The medium vessel vasculitis involves Pan and Kawasaki disease. And small cell vasculitis is further divided into ANCA associated and non-ANCA associated. So this is a picture summarizing which vasculitis can affect which are structures. Like when we take the involvement of veins, it becomes more in Yil's disease, hypersensitive angiitis, vaginous granulomatosis, and also allergic granulomatosis and CNS vasculitis. And also we know Behçet's is very notorious to involve the venous system. So this also will give us little more clue towards a which vasculitis we are approaching with. But when we are thinking about a primary vasculitis, it is always important to think about the mimics, which are the antiphospholipid syndrome, arterioembolic disease, arteriomatous vascular disease, drug abuse, hypersensitive reaction, infective endocarditis, multiple myeloma, paraneoplastic syndrome, sickle cell disease. And then the secondary causes includes mainly the rheumatoid arthritis, SLE, scleroderma, hepatitis C and B infection, lymphoma, and solid organ malignancy. So these must also be considered when we are taking a call on vasculitis. So finally, the clues which we got was more favoring towards small vessel vasculitis or the palpable purpura, and we know the nerves are also involved in this patient. The other aspects we can only comment on after the investigations. So we were thinking more towards a small vessel vasculitis, which is causing the involvement of the muscle, nerves, skin, and also Raynaud's phenomena. So first we reviewed the investigations which the patient underwent in the other hospital. The MRI spine with the brain screening was done, which was normal. A CSF study was done, which was normal. She was started on steroids, and because of the worsening of LFT, she was referred to our center. We reviewed the earlier NCV, which was done before she came to our hospital. Here we can see in the NCV, the motor conduction study, the amplitudes are reduced and also the distal latency is also prolonged. Interestingly, in the amplitude, we are getting only the distal pickup and proximally we are not getting, suggestive of a conduction block. And this is a picture in upper limb and also the lower limb. And sensory examination pickup, the snaps are almost inelicitable and F waves are also absent. So we went ahead and evaluated the patient. The evaluation initially, the CBC was total counts was 24,000. CRP was 22, ESR was 62, RFT was normal, electrolytes was normal. In LFT, SGOT was 1100, STPT was 472, INR was normal, TFT was normal, LDH was 2270. And then CPK was 77,000, urine myoglobin was 3+, and our repeat NCV showed almost a similar picture. That only the distal pickup, the amplitude was very reduced but present with the prolonged latency. Otherwise, proximally, we are not able to record. Even if recorded, there's evidence of conduction blocks. So that was the picture in motor conduction studies, and F waves are absent and snaps were also not elicitable in upper and lower limbs. So now we were strongly considering with all the markers, we went ahead and did a antibody workup. And the myositis panel and the ANA panel both showed anti-Rho52 3+. So that was the picture we got. And then considering her age, old age, above 50, so we thought we should also look for a paraneoplastic etiology. So a PET CT was done, which showed no metabolically active primary in the current study. So with that picture, we came to a clinical diagnosis of overlap myositis because it's a muscle involvement with connective tissue disorder or rheumatological disorder with fulminant vasculitic radiculoneuropathy secondary to anti-Rho 52 mediated systemic small vessel vasculitis. So this was the clinical picture, and now the discussion will be carried on by Gopi sir.
Thank you, Dr. Juno. So I'll just discuss some of the interesting nuances of this case actually. So the first interesting thing in this patient was that initially the patient had symptoms more suggestive of a Raynaud's phenomena, which was thought to be a carpal tunnel syndrome. Now, actually, if you think about it, both Raynaud's phenomena as well as carpal tunnel syndrome can present with very similar symptoms. All of these, both the conditions, the patients will complain of paresthesias, numbness, pain, and clumsiness. So it is actually at the just at a face level, it is difficult to differentiate between the two conditions. Now, what really sets apart the Raynaud's phenomena from the carpal tunnel syndrome is the skin changes or the color changes which happens at the time of the Raynaud's phenomena. But then again, in dark skinned individuals as well as in individuals with only minor symptoms of Raynaud's phenomena, the skin changes may not be very apparent. So whenever we have a patient who presents with carpal tunnel syndrome and we are finding something atypical in it, for example, the patient is too young to develop carpal tunnel syndrome, or the patient is a male patient developing carpal tunnel syndrome, or when patient has carpal tunnel syndrome more on the non-dominant hand, then these are certain red flags in which you need to consider alternate possibilities for CTS. And one of those possibilities which warrants questioning, we have to directly ask the question for that is Raynaud's phenomenon. So to make things slightly more complicated, actually there is Raynaud's phenomena and carpal tunnel syndrome can often coexist in the same patient. So there are three ways in which this can happen. One is because carpal tunnel syndrome is a condition which is having a good prevalence, large prevalence in the community. Raynaud's phenomenon happening in such a patient may just be a matter of chance association. The second is that there are many conditions like rheumatoid arthritis or in scleroderma, which can cause both carpal tunnel syndrome as well as Raynaud's phenomenon. And finally, carpal tunnel syndrome per se can trigger a Raynaud's phenomenon. So interestingly, this is a case report. It's a case series from 1985 in which they report 3 patients who had both carpal tunnel syndrome as well as Raynaud's phenomena. And all the 3 patients had the Raynaud's phenomena more on the side with the carpal tunnel syndrome. And in 2 of these patients, the symptoms of Raynaud's were completely relieved by carpal tunnel syndrome decompression. So this is some strong evidence arguing that carpal tunnel syndrome can itself precipitate a Raynaud's syndrome. Now, another interesting aspect of our patient was the electrophysiological findings. So given the clinical setting of the patient, that is, she has definite evidence to suggest a vasculitis which is at play. She has definite cutaneous evidence of vasculitis. We have a strong antibody positivity. And generally in the setting of a vasculitis, we expect axonal neuropathies. So if we just go through this conduction, it's quite interesting in that the patient has prominent conduction blocks. So you're getting good potentials on reasonably good potentials on distant stimulations, whereas on proximal stimulation, the nerve is inelicitable or inexcitable. So whenever we talk about conduction blocks, we always tend to think in lines of demyelinating neuropathies. But this is not always true. In the setting of a fulminant necrotizing vasculitis, this itself can present with conduction blocks. So this is called pseudo conduction blocks. So here it's not actually a demyelination which is happening, it's rather a direct axonal injury which is happening. But because we are doing the conduction for the patient so early into the disease, the Wallerian degeneration is yet to set in. So the distal stimulation is still able to pick up potentials, which is why you get a conduction block in this case. So whenever we find a conduction block, it shouldn't be assumed that this is always a demyelinating neuropathy. But our patient actually had some features to suggest a demyelination also. So if you look at the lower limb conductions, the distal latencies are significantly prolonged. 8.13 distal latency is in one left side is 10.52 distal latency. So these are significantly prolonged, and you can say they are in the demyelinating range prolonged. So how can we explain that? So at this point, we can just postulate. So one postulation we think is that the patient, because of the vasculitic neuropathy, because of the ischemia caused by the vasculitis, that region may have undergone a ischemic demyelination. So they may in fact be a demyelinating component also for this patient. Another possibility is that the patient, because of the Raynaud's phenomena, because of the cooling of the limbs, it may be just the significant cooling of the limbs which can cause a prolongation of the distal latency just because of the temperature. We have not corrected for the temperature when we did the conduction. So the distal latency prolongation may have just been added on by the coolness of the limbs. So another more interesting thing which we in our patient was the simultaneous muscle and nerve involvement. So our patient definitely has signs of nerve involvement with definite sensory symptoms, electrophysiology evidence of neuropathy, and definite muscle involvement in the form of significant myoglobinuria and raised creatine kinase levels. So at this juncture, we think it is most likely related to a systemic vasculitis, which has caused a radicular neuropathy along with an overlap myositis. Now, when we talk about myositis, inflammatory myopathies, and vasculitic neuropathies, we generally tend to think of these as two very different conditions, but this is not entirely true. So if we have to look at the pathogenesis of overlap myositis and dermatomyositis, it is the current school of thought is that it is actually triggered by antibodies which are directed against the endomysial capillaries. In fact, in other words, it's a vasculitis of the capillaries which is happening in the muscles. And because of this vasculitis, there is an ischemia to the muscle fibers. And this muscle fiber ischemia is in a large part what contributes to the muscle fiber necrosis and damage in dermatomyositis and overlap myositis. So the reason why we get this perifascicular atrophy, which we characteristically see in these conditions, in dermatomyositis, also in overlap myositis, is because these are the perifascicular regions are the parts of the muscle which are most prone for hypoperfusion. So in fact, you can, in other way, you can say that dermatomyositis and overlap myositis are in fact just vasculitis which is happening inside the muscle. Also, if you look at the literature, there are lots of reports where patients have had an inflammatory myopathy coexisting with a vasculitic neuropathy, mostly in the setting of rheumatoid arthritis, some in the cases of dermatomyositis and other inflammatory myopathies. Finally, I'll just talk briefly about our the positive antibody which we got in our case. So Rho52 antibody, it actually localizes to a cytoplasmic protein, which is involved in the ubiquitination of other proteins. Originally, this antibody was described in Sjogren's syndrome, but later on it was found to be associated with other conditions also, including systemic sclerosis, idiopathic inflammatory myopathies, interstitial lung disease, mixed connective tissue disease, primary biliary cholangitis, and rheumatoid arthritis. There isn't a lot of literature about Rho52 mediated overlap myositis, but generally it is known to be associated with Raynaud's in about 25% of the cases. It has a strong ILD association. Interstitial lung disease can be seen in about 40% of the cases. Our patient did not have interstitial lung disease on a CT chest. Joint manifestations can be seen in about 45% of the cases. Also, Rho52 antibody is commonly seen in association with a Jo1 co-positivity, anti-Jo1 co-positivity. Our patient, in fact, had an anti-Jo1 negative, but this is a common association which is reported. Finally, generally, these patients tend to have a less optimal response to treatment and rarely attain complete remission, and they generally have poorer functional outcomes on long-term follow-up. For our this is there is in fact there's one case report. This is from Korea of a 42-year-old male who had dermatomyositis with the Rho52 and MDA5 positivity, who additionally had a sensory motor axonal neuropathy and later on goes on to develop a vasculitic peroneal neuropathy. So in Rho52 positive overlap myositis, also this neuromyositis has been described previously. So for our patient, she has been treated with, she's received 5 days of IV methylprednisolone, after which she has received IV immunoglobulin as well. And following this, she has some improvement in her proximal power. She's still not ambulant. She can, however, lift her limbs from the bed currently. Her creatine kinase levels are improving, almost back to baseline. Her myoglobinuria has resolved. The digital ischemia from the Raynaud's is also improving in our patient. And currently we are planning for rituximab followed by an oral steroid paper. And the patient is currently still in a ward actually. Thank you.
Thank you, Dr. Gopi. There are some questions in the chat box.
Oh, sure, sir. So I'll just go through some of the questions here. So one is, can toxic presentations like arsenic explain the neuropathy and skin lesions? Yes, they definitely can explain the skin lesions as well as neuropathy. So classically in arsenic, you have the raindrop type of hypopigmentation, which is classically described. They can also have significant hyperpigmentation of the skins, and as well as it can have a GBS like very acute presentation also. So initially in the history, that is something which we can strongly consider in this patient. Secondly, we have a question. How do you say that the sensory loss is graded? Can there be any objectivity? So generally by graded sensory loss, we mean that the distal parts, the sensory loss in the distal parts are greater compared to the proximal parts. So what we generally tend to ask the patient is, as we are, we'll be testing the pain sensation here, as we go more proximally, is the sensation gradually improving? So once, if they give such a history that it is gradually improving when you move more proximally, that is suggestive of a graded sensory loss. And generally graded sensory loss is basically, it means we are dealing with a length dependent neuropathy here. We have a question, what did the needle EMG reveal? Actually, we did not proceed with the needle EMG for this patient because we knew that, I mean, we had definite evidence for a neuropathic involvement and her CK levels was about 70,000. So we did not proceed with the needle EMG because we were pretty certain that we were dealing with an inflammatory myositis along with we had other evidence of electrophysiological evidence for a neuropathy. Next is, can we consider the possibility of myositis with compartment syndrome and neuropathy is secondary to this? The ANCA levels were not mentioned. Okay, so yes, so myositis causing compartment syndrome, which can leading on to neuropathy, is actually a good possibility for this patient. But clinically, actually on examination, there is not much evidence of a compartment syndrome. There isn't much of an inflammation or tightness of the compartments of this patient. And it is not a single compartment actually which is affected in this patient. She has evidence of neuropathy involving both the limbs, involving the posterior compartment of the leg, anterior compartment of the legs, as well as in the upper limbs. Also in the distal sural snaps are also ineligible. So just by a compartment syndrome in this in our particular patient, I don't think that will completely explain the symptoms. The ANCA levels were not mentioned. We're sorry about that. The ANCA was negative for our patient. However, the DTR, dependent reflexes were all absent. All the reflexes in the patient, upper limb as well as lower limbs, were absent in our patients, which can be both part of the neuropathy as well as the myopathy in our patient. Was a triple biopsy of skin, muscle, and nerve contemplated? Because we had some definite clinical evidence for vasculitis. We had definite leukocytoclastic vasculitis evident from the typical skin lesions. We had evidence for strong antibody positivity in a patient with a Rho52 positive, both from the ANA profile as well as the myositis profile. And because we have definite evidence of muscle inflammation, which was actually very strongly seen in the PET scan, we did not actually go ahead with biopsy because more of an invasive procedure, which we did not feel would yield much with respect to the patient management part. Anti-PRT, no, our patient had our patient was anti-Rho52 positive. I'm not sure about that condition, sorry. Considering the significant clinical suspicion of vasculitis, would cyclophosphamide be a better second line compared to rituximab? So generally in systemic vasculitis also currently there is a change in trend from going for rituximab rather than cyclophosphamide. There are non-inferiority trials comparing both rituximab as well as cyclophosphamide in systemic vasculitis, especially ANCA-associated vasculitis, even in non-ANCA-associated vasculitis. And generally, because the side effect profile is thought to be better for rituximab as compared to cyclophosphamide, currently even the rheumatology colleagues will also agree to that. The general trend is to go with rituximab over cyclophosphamide.
Wonderful case by sir. I thank Professor Anand Kumar for an excellent case, and I just wanted to know one question to you is whether there is a distinct entity of Rho SLE. You know that even the phenotypical presentation is slightly different on the Rho SLE than the normal SLE, and similarly, is this Rho antibody? Is there any difference between the Rho Sjogren and this? Hello? Hello? Hello?
Yes, sir, please continue.
Is there any distinct entity called Rho Sjogren? Like Rho SLE?
Sorry, can we just repeat that question? I couldn't get the question. Sorry.
There is a distinct entity called Rho SLE, with a
Yes, sir. Rho
different
positive.
phenotypical Rho positive SLE, which is
Yes,
slightly different from the routine SLE.
Yes,
Is this Rho Sjogren is different from the normal one?
Sir, our patient actually had a myositis presentation. It's an
No, I
overlap.
know. No, I'm not talking
Yes,
about your. I'm not talking about.
Yes, sir.
I'm asking you.
Yes, sir.
There is a distinct entity called Rho positive Sjogren, like your.
Yes, sir.
Because your Rho positive, Rho 52 is highest positivities in Sjogren. Do they phenotypically differ from the normal Sjogren, or is it the same?
No, sir. So generally, SSA and SSB of the SSA, that is Rho 52 and Rho 60 antibodies are there for Sjogren syndrome. Phenotypically, they are not different, but generally, the positivity rates, the Sjogren tends to more commonly present with Rho rather than La, that is SSB. That is the other spectrum of, but clinically, I don't think they're
not much
behave
of
differently.
difference.
They're not much different, sir. In Sjogren, sir.
Yeah, my congratulations to you for wonderful case. Only thing is, and Professor Anand Kumar is there, sir. You are.
Okay.
Sir, good evening, sir. Good evening, sir.
Good evening. Good evening.
And I managed to get some connection deep in the forest. And there is not much of connectivity here. Anyway, I'm very so happy to see you, sir. Thank you so much for a wonderful case, and we are very much indebted to you for a lovely case. And now we all understand that the skin, muscle, and the nerve, the neuromyositis entity, it's definitely a distinct entity where there's a presence as overlap myositis, and my extreme thanks to the entire Amrita team for this wonderful presentation. Sir, Professor Sudhir Shah, sir, would you like to add anything?
Hello. Yeah.
Yes, sir.
Actually, I'm in a vehicle and traveling, so a lot of connection issues right now. But I could say this is one of the most challenging and wonderful case with protein clinical manifestations, and they have worked up also very nicely. And the proposed hypothesis is also very interesting. So I think it's an eye opener that one can have myositis with roller positivity, and then other side you have vasculitis with nerve and radical involvement and all that. So I must compliment the whole team for the wonderful workup and good diagnosis. In between, my connection was lost, but did we have any biopsy finding of this patient?
So no, sir, we have not done biopsy for this patient. We had definite antibody evidence to suggest vasculitis and overlap myositis.
Okay.
So we didn't go for a biopsy, sir.
And also regarding PET scan, what did you say? PET CT?
So PET CT was primarily done for two things. So one, to confirm the muscle uptake, which was strongly there, but there was no evidence to suggest any malignancy in the patient.
Okay, fair enough. Yeah.
Yes.
Thank you so much. Wonderful.
Thank you, sir.
Dr. Lakshmi, you may please conclude.
Can I make some
Yes,
concluding
sir. Dr. Anand,
remarks?
yes, we want to listen to you, sir. Please.
Okay, thank you. First of all, I am very much excited to see Dr. Lakshmi. And I also thank Gopi Krishnan and Gino for having conducted a clinical biopsy. And this term I'm borrowing from Lakshmi because he used it once. I congratulate them for the in-depth discussion. I would like to make some very general observations, or if I'm putting it in another way, I want to share some neurology secrets. So when you have a problem case at hand, like the one we had, there are certain lead points that beckon you to follow them. So they are telling you, please follow me or follow us, and you will reach the correct destination. In this particular case, it is a typical presentation and Raynaud's phenomenon, skin changes, and the high colored urine. As regards the atypical presentation, one should always remember that patients do not follow textbooks. Variation is the rule of nature. Just as one person is different from another, the way the disease manifests in one person is totally different from another. That is why clinical neurology is so challenging. The era of personalized medicine is ushering in, and I always wonder why it took us so long a time to realize this basic fact that one size doesn't suit all. So always try to locate the leading lights and follow them. And whenever you start prescribing, think about the patient factors, disease factors, and drug factors. So this case classically exemplifies that you have to have a customized or personalized approach in clinical medicine. And also, when you take your pen to prescribe, think whether it will be prescribed for yourself or your immediate near ones. If the answer is yes, you can go ahead. And the second point I wanted to make is, as a very gross generalization, I believe that disease processes have three main I's. I mean the letter I. So these are infection, inflammation, and immune mediation. I repeat, these main three pillars on which this disease processes stand are infections, inflammation, and immune mediation. In a given case, one may dominate. Take, for example, tuberculosis. Tuberculosis has got an infective component, an immune-mediated component, and of course, inflammation. And what you should be careful about is the inflammatory component. If the inflammatory component goes out of hand, then it is definitely going for a very bad prognosis. When I say these three I's, it is not that I'm forgetting the other I's, such as infiltration, irritation, iatrogenic, and of course, idiopathy. So whenever you want to find the pathology or the mechanism, you should always think about the main three I's, that is infection, inflammation, and immune mediation, and try to find out which is dominating in a given case. For example, if you take multiple sclerosis, there's a strong theory that it's an infection which is triggering, followed by the immune reaction and of course the inflammation. In the case discussed today, what dominates is immune mediation. It is immune mediated small vessel, non-specific vasculitis with muscle and nerve microinfarctions with accompanying inflammation. So it's actually vasculitis, as Gopi was mentioning about the capillaritis, with microinfarctions occurring at the muscle level as well as at the nerve level. And of course, this process will not spare the nerve tics within the muscle. The reason why we get the typical EMG findings of neural as well as muscle involvement in myositis. But in this case, we are not talking about the muscle involvement of the nerve tics within the muscle, but we are talking about involvement of the radicals and the peripheral nerves. So there is a question about graded sensory loss. And when you find graded sensory loss, you can always consider a polyneuropathy, that is a distal symmetrical polyneuropathy, because sometimes the same presentations can happen at other instances, like for example, in a spinal cord lesion, when the specific laminations are affected, it can present with a pseudo-neuropathic picture. In such a case, if you are able to demonstrate a graded sensory loss, it will help you to further confirm that you are dealing with a peripheral neuropathies. And always ask for any emotional factor, especially when you come to autoimmune diseases. Lastly, I would like to pitch some ideas or food for thought. If we take a neurological problem solving process, the first attempt is symptom analysis and localization. However, when it comes to muscle, we directly jump to syndromic diagnosis. For example, we talk about limb girdle syndrome, distal myopathy syndrome, and the like. The result is that we don't make any attempt for muscle localization, just like we do for the peripheral nerve or the spinal cord. We don't make any attempt to localize to the muscle. And because of that, we don't have a mental imagery or picture of the muscle as we have for the peripheral nerve or the cord or the cortex. So just like the cardiac muscle, the skeletal muscle also has got the contractile part, and there's a conducting system, which is propagating the electrical impulses. There's a neural system, and there is also the vascular system, and also the parts or the processes which supply the metabolic demand of the muscles. So to make this concept more clear, I would like to share 2 slides or 3 slides. This shows the cytoarchitecture of the muscle, that's at the molecular structure, where you have the sarcoplasm, the contractile elements, then you have got the cytoskeleton, that is a dystrophin complex and the like, and also the collagen and laminin mediated muscle membrane. So here, whenever we make a muscle diagnosis, we straight away go to the syndrome. We don't look at what part of the muscle is getting involved. Next slide. So here I have depicted the muscle has got a contractile system. It has got a support system, the cytoskeleton. It has got a neural or neuromuscular junction. It has got a conducting system propagating the action potential, and the energy supply system, the mitochondrial energy metabolism, and of course the vascular system, which is supplying the oxygenation and nutrition. Next slide. Yeah. So if you take I'm just making an attempt at a very surface level. For example, if you look at the conducting system, you can think about the ion channels or the channelopathies. Or if you're considering the extracellular matrix where the collagen is affected, like Bethlehem myopathy, or the cytoskeleton as it happens when there's a dystrophin and sarcoglycanopathies, or the contractile proteins as it happens in the congenital myopathy, and of course the mitochondrial myopathy with all its systemic accompaniments. Or it can be a blood vessel vasculitis as exemplified in the particular case under discussion today, the capillaritis, which clearly shows how you can localize the blood vessel. Or it can be some problem with the energy metabolism of as happens in metabolic myopathies, and the intramuscular nerve inflammation, that is neuromyositis. So what I wanted to pitch, the idea I wanted to float is that we also should make an attempt. These are all very elementary thoughts from my side. Some young minds will have to work on this and make a muscle localization paradigm. Based upon the clinical features and the examination findings, whether you are able to localize to the building blocks of the muscle. So that is something which I wanted to share with you, which has been in my mind for quite a long time. So we can do the neurological evaluation in the proper way. So with that, I conclude my discussion as well. I profusely thank Dr. Sudhir Shah and Dr. Lakshmi, whom I consider my kid brother, for giving us this opportunity. I learned a lot. And without doubt, I can say this is lifelong learning in neurology. Thank you.
Thank you so much, sir. And as usual, every time the slides which you show as food for thought make all the young neurology brain get ignited. And from now onwards, I think I'm sure that every one of us will try to look at the clinical findings to try to localize the different compartments in the muscle. I think this is a wonderful idea, sir. And we will all try to see how best we can localize among inside the muscle in the various, which could be the components. I'm really thrilled and joyed, and so also all the participants. I'm sure your last few slides are the best in the entire show. Now, I'm not underestimating the beautiful work done by all the work, but yours is extraordinarily brilliant. So thank you so much for the insight which you have given, and it's really stimulating. And I think we should work on the various parts of the muscle, the contractile proteins are involved, or the structural things, or I'm really thrilled. So thank you so much for your participation. We are honored. And over to Professor Sudhir Shah.
Dr. Shah, you're muted. Dr. Sudhir Shah, sir, you're muted. I guess we lost him.
Yeah, so we lost him.
Shall we close?
Yeah, please.
Narasimhan
Please
sir?
go ahead. Yes, sir, please.
I guess we lost connection of Dr. Sudhir Shah, but I'm sure he would have also liked to thank each one of us, especially faculty and all of you, for bringing a wonderful case on myositis plus syndrome. The entire faculty members of prestigious Amrita Institute of Medical Science, Dr. Anant Kumar sir, thank you so very much. Dr. Gopi Krishnan, Dr. Gino Vincent, and all those who were a part of this. Thank is also due to our program director, Professor Sudhir Shah and Professor Lakshmi Narasimhan, for continuing this Pearls of Wisdom for 2 years. And please do log in on 24th of June, which is going to be the second year in the making on Secrets of Neurology. A very big thank you to all the participants who have logged in very big number, not just from India, from across various neighboring countries. Thank you so very much. And just remember to log in on last Friday of every month for Secrets of Neurology. Thank you so very much.
Thank you, sir.
Thank you
you so
everyone,
much.
and good night.
Rohit, we can end.